Welcome to our program on alpha-1 antitrypsin deficiency. My name is Dr. Charlie Strange. I work at the Medical University of South Carolina, where I've been for the last more than 40 years. Our goal today in our 45 to 50 minutes together is to make everyone in the audience an alpha-1 expert. We know that alpha-1 is an important endotype of COPD, but it does have some nuances that need to be talked out, and particularly around the testing arena, just to make sure that your communication to your patients and to your medical communities is factual. And whenever I talk about alpha-1, I always have to mention my disclosures. There are more than 20 pharmaceutical companies that have drugs in the pipeline for alpha-1. I work with many of them and have those disclosures written out for you. And important to this talk, I'm a medical director at AlphaNet. AlphaNet is a not-for-profit organization that provides disease management to those with alpha-1 antitrypsin deficiency. And so through my group of alpha-1 coordinators, take care of more than 8,000 individuals with alpha-1 antitrypsin deficiency. Well, let's jump right in to our talk. And our first way to get started is to talk about what is alpha-1. And most of you know that alpha-1 is a genetic disease. The DNA abnormality tends to be a point mutation somewhere in the SERPIN-A1 gene. SERPINs are protease inhibitors. They function across lots of different biologic systems in the body. And yet in the lung, they serve as a natural inhibitor of some of the proteolytic enzymes that drive emphysema in the lung. Our two major abnormalities in the DNA of alpha-1 antitrypsin deficiency are two alleles that are variants called S and Z colloquially. They have very technical names at the DNA level, and we'll mention those as we move through. It's predominantly the Z gene, though, that creates problems in the biologic systems that protect the lungs. And particularly this Z allele and its associated protein sit at an important hinge region of the alpha-1 antitrypsin molecule. Alpha-1 antitrypsin, a good chemical, helps protect the lungs from neutrophil elastase and other proteases in the lung. And this Z hinge region will function okay, but what happens when it is synthesized in the liver, which is the third panel, is that it misfolds. And as the Z allele misfolds inside the endoplasmic reticulum of the liver, we get globules of accumulated alpha-1 protein that just can't get out of the liver. If it can't get out of the liver and our blood level is 10 to 15% of what it should be, then we don't have enough alpha-1 to protect our lungs from cigarette smoke, dust, fumes, and other irritant substances within the lung, and then has an important infection clearance role as well. And what happens if your lung can't protect itself, and particularly if there are excess injuries to the lung, such as cigarette smoke, then we get lung disease that in this disease is emphysema predominant, but not all emphysema, as we'll talk about in our course. So that's our overview of alpha-1 and what we're going to be talking about for the next 45 minutes. So SERPIN-A1, some people call it SERPINA1, it's really the serpin that encodes for alpha-1 antitrypsin. It has some transcriptional elements outside the gene. There are actually about 500 different variants of this gene that have been described. Some of them are pathogenic, some of them are not. It's on chromosome 14. But these most common S and Z alleles have their single point mutations each and could be targeted by DNA targeted therapies. This is a very old nomenclature system because we ran out of letters, A, B, C, D, S, and Z many, many years ago. And so you'll see some unusual nomenclature. And there is a move afoot to change some of the nomenclature similar to other genetic diseases. And if you are in the middle of that transition and don't know what your gene report actually says, and you might have a rare gene, then there is a website that details the 150 most common of the 500 genes out there. It's called alpha1alleles.com, and it actually lives on the AlphaNet website up in the header. And so that is kind of where we go towards from the genetics. The next piece is that as the gene is then transcribed through RNA and makes a protein, we have the whole concept that the protein gets trapped because it doesn't fold well. And the particulars of the folding have been known now for about 25 years, is that the C terminus of that protein actually binds to another alpha-1 molecule. And on the far panel, you'll see an electron micrograph of these little beads on a chain, or almost looks like a necklace, that is a long string of alpha-1 molecules called a polymer. This polymerization function can be short, it can be long. And these polymers actually make it out of the liver cells, the hepatocytes, into the bloodstream. It might be one of our biomarkers for liver disease. And so we're going to put a lot of focus in the liver disease of alpha-1 on polymers and how to prevent them. And it's been shown that these polymers also play a role in the lung disease of alpha-1, and that is still being elucidated. Okay, let's turn to the lung disease. This is the COPD Foundation conference, and the Alpha-1 registry was formed right after the National Heart, Lung, and Blood research study that ran for 5 years. And many of us in the Alpha-1 field started accumulating patients that were populated into the Alpha-1 Foundation registry. And so this registry has then survived now for more than 25 years in different iterations. And from the registry, we do get a biased population. First, those that have been diagnosed compared to those that have not been diagnosed. But this whole concept of what kind of lung disease is actually out there is really pretty interesting, because when you ask the patients what they've been told by their healthcare providers, then number one diagnosis is emphysema, as we'd all expect. But if you look at the Venn diagram, this is what actually was told to the patients over time. And notice that there are people that have been told that they have pure asthma, chronic bronchitis, pure emphysema. But the most common scenario is that the patient community has been told they have more than one pulmonary diagnosis. The other important thing to say, that even though this is emphysema predominant, is we have a lot of wheezing, a lot of cough, a lot of airway symptomatology. And what's not on this slide, because we didn't do CT scans back in the early 2000s very often, is bronchiectasis that also has an overlap with these diseases, and we'll talk about that a little later. The last thing to point out is that the liver disease population is not different, that 2/3 of the diagnosed liver disease population in our old registry format, which was really a lung-focused format most of the time, but 2/3 of those individuals with liver disease had lung disease, and so the possibility that liver and lung disease overlap is very prominent in this community. And yet there are individuals that present with liver disease alone and on CT scan and lung function tests have completely normal lung disease as well. So that story is being written, and it's being written in a different way because our hepatologists now are screening for liver disease with much more frequency now that we have therapies that might make a difference in the disease. I want to kind of roll you through our concept of what happens in the lung with alpha-1. And on this little cartoon, we have alveoli and a small airway. Those little lines on the slide are the elastin fibers that are prominent in the lung, and we'll see them on any sorts of elastin stains. But these elastin fibers help hold the airway and produce some of the small airway competency that's due to the connective tissue matrix of that lung. We know that when elastases coming either from neutrophils or macrophages are prominent in the lower airway, they can cleave these elastin fibers and eliminate them. And our lung is protected by a whole group of anti-elastase chemicals, also called antiproteases. And the most prominent of those is alpha-1 antitrypsin deficient. Alpha-1 antitrypsin. Alpha-1 is kind of like the big gorilla in the lung. It's the second most abundant protein in the body behind albumin. And because there's so much alpha-1 there, it has to serve an important function of lung protection here. Secretory leukoprotease inhibitors, some of the cathepsins and others are anti-elastases as well. But the concept here of what happens in the lung is that if you were to further damage the lung by bringing in excesses of neutrophils into the lung, particularly if they're activated, the neutrophil elastase overwhelms the protection of the anti-elastase of alpha-1 antitrypsin. And what then happens is that we start losing elastin fibers in our small airways. If you lose elastin fibers between two adjacent alveoli, they coalesce and form emphysema. If you lose them on the small airways, then any positive pressure will make those small airways collapse. And that is the obstruction of emphysema, for which we really don't have good medicines to affect change. We can prevent progression, but we really can't grow new elastin fibers in the small airways right now. We hope we can in the next era of generative medicine. And so the lung damage is really twofold. It happens because we have excess neutrophils in the lung. And think about the ways we get extra neutrophils in the lung. Well, that's every respiratory infection you have, cigarette smoking, or if you work in an environment that has fumes and dust and particulates. And so one of the goals is to kind of live in a clean air environment if you have alpha-1 antitrypsin deficiency. And for that matter, all of COPD and prevention of lung disease progression. On the other side is the amount of alpha-1 that you have inside the alveolus. And this anti-neutrophil elastase protection is important, and it's the biochemical basis on which we think that our augmentation therapies actually have utility. I want to show you a few old historic concepts that haven't changed all that much. And in 1994, Dr. Stoller in the Cleveland Clinic Journal of Medicine actually reported the experience of patients that were actually being seen at their center and how long this diagnostic journey was. How many healthcare providers did it take before you actually had an alpha-1 diagnosis established, and how much time does that take? And what he found was the mean age at first symptoms was 35 years, and the mean age at diagnosis was 41 years for an average 6-year diagnostic delay. This is altered a little bit over time. When the disease was first really described, this early onset of emphysema was very prominent. But you have to remember that was an age in the United States when cigarette smoking was on every street corner, and importantly, some of that has regressed now. So the average age of diagnosis in many of our diagnostic laboratories in the United States is age 60 to 65. And so it means that we've transitioned, importantly, towards less cigarette smoking and therefore a older age at alpha-1 diagnosis. And that has a lot of implications for who we screen and test. And so if you're still screening just the young presenters with COPD-like symptoms, including asthma that doesn't respond appropriately to therapy, then you're going to be missing the majority of patients with alpha-1. The other important concept here is that if you smoke, then your symptoms actually do present very much more frequently. And one of our important historical cohorts in alpha-1 is the Swedish study in which from 1970 to 1972, every baby born in Sweden got tested for alpha-1, trying to understand the natural history of disease. These babies are now 55 years and older, and they were all told not to smoke, and yet 21% of them at the time in Sweden did smoke, and their symptoms are much more prominent in phlegm, dyspnea, exertion, and wheezing than those that took the advice and never smoked over the course of time. And so smoking and that airways injury is an important part of who gets symptoms and who doesn't. And further, to kind of show this heterogeneity in the alpha-1 community is a sibling pair study done at the Brigham. And this is also an older study, but brothers and sisters with ZZ genotypes were actually asked to come and get lung function testing. And on the x-axis, you see age, and the non-smokers are in red dots, the smokers are in blue dots, and we see this presentation of clustering of the blue dots down the bottom left of the slide, which is our historical cohort, early onset emphysema, very low FEV1s, the y-axis, and it just shows that from that left bottom corner upwards, the heterogeneity is really marked. And some of that is based on smoking pack years, but others of it is not. And so this study was actually done trying to find other biologic mediators of the consequence on lung disease, why some ZZs have actually normal lung function out into their 70s or 80s, and others actually present very early in life with bad disease. And so if you end up only testing those individuals with the historic classic presentation of basilar emphysema at early age, you actually end up missing 75% of the ZZs that might respond very nicely to therapy. I would note that there's some smokers up there in blue with normal lung function at age 70. And so what this study also taught us almost 2 decades ago was that we shouldn't screen our patients really just on severity of disease and age. And so there are plenty of smokers that actually have alpha-1 ZZ deficiency. Just because somebody smoked a lot doesn't mean that we shouldn't do the once-in-a-lifetime rule-out test to make sure that they don't have disease. So our recommendations for testing are solidified in the 2003 guidelines and really repeated in the COPD Foundation guidelines that then followed. And that's early onset pulmonary emphysema, as we've always known it. But you look on down the list, it's all subjects with COPD. And because this is really a genetic disease, a once-in-a-lifetime test is all that it takes. An alpha-1 antitrypsin level at my hospital costs somewhere in the realm of $25 or $30. So if you think how many different ways we spend $25 or $30 in the COPD world, a single test in a lifetime that costs $25 for an alpha-1 level is really not too much to ask. The others on this list, adults with bronchiectasis without evident etiology, and next to last one there are patients with asthma whose spirometry does not return to normal with therapy. And when you ask our patient community what their first wrong diagnosis was, it's usually asthma. And it just means that you come in rather young with cough and wheeze, and your primary care provider appropriately thinks this might be asthma and applies therapy for some period of time. And the point is that asthma is a reversible disease, therefore it should completely reverse. If it doesn't, time for the alpha-1 test, as opposed to testing 5 to 7% of the U.S. population that might have asthma. We do have some other diseases. Paniculitis is an inflammatory disease of the fat-containing regions in the body, often on the thighs or the abdomen. It is a sore area that then sometimes gets ulcerations and then doesn't heal very well. Alpha-1 augmentation therapy often assists in the healing. We do have some vasculitis diseases associated with low levels of alpha-1, such as the PR3 vasculitis spectrum of diseases. So let's move on to our genotypes and levels. And this is a little bit complicated for the community that isn't used to dealing in the different units that are sometimes used in alpha-1. And many of us have heard this threshold of 11 micromolar and lower being what we target for therapy. And the micromolar system is an international system of how much protein is in the bloodstream or in the lung. The comparable laboratories in the United States usually report in milligrams per deciliter. And so there's a lot of confusion in the patient community between the two measurement systems. The 11 micromolar threshold, below which we're going to find all the ZZ individuals and all the Z null individuals, is equal to 57 milligrams per deciliter. And most of our laboratories report somewhere around 100 and higher milligrams per deciliter is in the normal range. So anything in the abnormal range means that you can have any number of different allelic two letters. And in this case, you see that these bands of the alpha-1 levels for MMs and MZs and SZs and CZs are actually quite large for the majority of our allelic combinations. And in particular here, the bands are wide because of a thing called the acute phase response. And so when your body is under stress defined broadly, then what happens is the alpha-1 production in the liver actually goes up at a translational level. And what happens then is your sickest patients, those with an exacerbation, are going to actually have rather high alpha-1 levels in the normal range much of the time. And particularly the MZs and the SZs, the lower the level is going to reflect those patients that are really not ill at all. And so, yes, you can test levels as often as you want to, but you really only need one if you're looking for ZZ and Z null individuals. And this concept of when to test and what you're testing for is an important one, because if a family wants to generate their family tree, and we'll talk about family testing in a moment, then to find the MZs, particularly a sick MZ in the family, means that oftentimes their alpha-1 total level is going to be in the normal range, and therefore you'd have to do a test that actually tests for the individual alleles and find the genotypes associated with a family testing. For all practical purposes, right now in the United States, we have recommendations to treat ZZ and Z null individuals and SZs with very low levels who have emphysema. And that indication means that an alpha-1 level to screen for that population is adequate because it will always be less than 57 milligrams per deciliter. When people have levels of 60, 70, 80, then this low level often indicates that we have a more either heterozygote composition with MZ or MS or an SC disease state. So let's just kind of get the genetics out there. If everybody only gets two letters in their name, only two genes, one from mom and one from dad. And so an MM marries an MM, all the kids are going to be M. And an MM marries a ZZ, then every kid is going to be M and Z. And you don't really have to test unless there's non-parental transmission of genes in a family. We do have families in the United States where a ZZ is married to ZZ and all the kids are ZZ, as you might imagine. Probably the most common combination is an MZ marries an MZ. And in that situation, you have a 25% of children being MM, 25% being ZZ, and then a 50% chance of the kids being MZ. And so being able to actually just draw this out for a patient who's coming to see you for alpha-1 really helps an understanding of kind of who in the family to test, siblings being most important, particularly if you have one ZZ individual that are finding you. The other point to make is because the Z allele frequency in the United States is 2%, the S allele frequency is 3%, that 95% of individuals are MM. We have all these other genes, but they're very, very rare. But you will find about 10 times more MZs in a testing program than you will ZZs. And so being able to talk about the MZ state, chance of transmission to children, testing the spouses to know if there's a chance that a child could be ZZ, are all important parts of becoming an alpha-1 expert and kind of talking through the family history. Remember that when we find an individual with alpha-1, we're identifying a family, and so we're not always set up to do family testing, and for that reason, there are now national testing programs for free available through the Alpha-1 Foundation and through some of the pharma companies. Alpha ID Online was the first FDA-approved genetic test that was that can be found on the web and mailed to your house and get a diagnosis for free through the mail. And so there are plenty of ways to test the family. If they're extended, it just takes to kind of talk about the genetics and the risks and how that should flow is an important part of our genetic medicine. We have a lot of MZ and MS carriers, so if you're going to do testing, you ought to know what to say. Lung disease and liver disease is more frequent in these Z carriers of 1Z. And if you put smoking plus an MZ genotype together, then we do have more COPD than smoking plus an MM population. That's good science. And what we know in the liver disease is that if you're MZ genotype and you add the metabolic syndrome with obesity or diabetes, then there's more liver disease. And so our message is to the carriers, both MZ and MS, is to live in a clean air environment, keep your weight normal, and don't add other liver injuries to your disease state. So we do have a lot of barriers to detection. Most of our COPD, as many of you know, resides in primary care. And I think in our medical chart, we have a hard time figuring out who's been tested before, particularly in the electronic medical record, and particularly if these tests go out into some media file that gets lost. And so one of the ways I do that and know who's been tested is that when I write in my problem with COPD, I actually put MMCOPD, and that means that I know they've already been tested for alpha-1 antitrypsin because I wouldn't know they have two M genes. And the point here is that the testing is all biochemical testing. You can't look at somebody and figure out who has alpha-1 and who does not, because they look just like every other COPD patient in your practice. We have empowered our respiratory therapists here at the Medical University. We've done 2 studies on this that show that respiratory therapists are capable of transmitting the message. We do it in our pulmonary function lab. If someone has obstruction, then they are offered testing at that point. These do require some signatures and a healthcare provider is the lead in diagnostic testing, but setting up a program at your own hospital is certainly something that can be done and is successful. Our tobacco exposure is common in the individuals who are diagnosed with alpha-1. And because we don't really have a birth testing program in the United States, then we recognize that the majority of individuals diagnosed in our community in a very early study from Dr. Campos here, 82% of the 1,000 patients tested in this AlphaNet study were former smokers. And so when you put smoking plus alpha-1 deficiency together, you're going to have more severe disease. And so to kind of know how often we're having more severe disease is the time to diagnose alpha-1. We would rather be diagnosing our alpha-1 at age 30 or 40 with the first cough and wheeze at a time when lung function is normal rather than when lung function is severely impaired. And so don't let tobacco exposure really bias your testing for alpha-1. We also know that if we do define even an MZ genotype and give the message that this is the protective chemical that you don't have in your lungs, that the majority of people actually make smoking cessation quit attempts and this hard journey of smoking cessation, which is a very important message. Well, let's talk about our therapies. Our current formulations of alpha-1 antitrypsin as a therapeutic were developed at the National Heart, Lung, and Blood Institute at the NIH in 1987 and given to patients there between 1987 and 1989. It was licensed on the basis of biochemical efficacy in 1988, and that makes this drug more than 30 years old. And it's been given at 60 milligrams per kilogram, the dose that actually achieved that 11 micromolar threshold. And we have a lot of information about the drug utility, what it does and what it does not do. These are pooled plasma preparations with a theoretic risk of viral infections, but because of the standards imposed upon the plasma pool to check for virus at multiple steps along the way, and then having nanofiltration and detection, there has not been a case that has been noted of viral transmission in the 30 years that this drug's been out there. That whole process, though, makes it a very expensive drug, not to mention that you have a once-a-week infusion for the rest of your life to be on this group of medicines. When you get an infusion, your blood levels go up in the micromolar scale to 25 or 30. If you give a double dose, it goes up higher than that. And the point is that these doses don't really respond in a natural way to that acute phase response that happens during times of stress. So the message, should you end up having a patient come into the hospital, is to try and get their dose to prevent the lung inflammation that happens during those acute phase stress events in the lungs, in which lung can be impaired. We know that this drug impacted survival and the National Heart, Lung, and Blood Institute registry. And we're really struggling trying to figure out how to measure progression of emphysema as an outcome measure in many of our trials. This is one of my favorite slides. If you've heard me talk before, I use it a lot, but it's a nice CT scan that shows the smattering of dark areas inside the lung that are emphysema. And we recognize that the radiologists often point out the 3 millimeter nodule, but don't mention the emphysema in there. And this one, they also just couldn't help but mention the pack of cigarettes that are still in the front pocket of the patient here. But this whole concept of density in the lung and how to measure it means that for every little tiny square of an image here, in a CT scan, a three-dimensional square called a voxel, has its own separate density. And what that means is that we can make a density histogram of the lung. And as you have more emphysema, you have more air in the lung and less connective tissue. And so these curves shift, and they give us some metrics around how much emphysema. We can measure it. We can move with time as long as we keep lung volumes the same on the measurements. So there's a lot of technical components to measuring CT density accurately. But this is the study that has been done to actually show that our therapies make a difference in the rate of lung density loss over time. In this case, the bright green line was the rate of tissue density, grams of tissue per liter per year lost on placebo drug for 2 years compared to the blue group, in which patients were getting the usual dose of 60 milligrams per kilogram of augmentation therapy. The orange bars, when at 2 years, the group who had lost more lung density were switched onto active drug, and actually has a statistically significant slope change in the rate of CT density decline in the total lung capacity, lung density slopes, and the rapid study done studying Zemera. And I think the point is that this prevention of progression of emphysema might not seem like a lot, but if you do this year over year, what happens is that you end up with transplant and disability very much sooner. And so emphysema is a slowly progressive disease. We don't have good tools other than CT density to measure it. And that's part of the problem of our trials in alpha-1 antitrypsin deficiency. So we recommend that we have the best data for intravenous augmentation therapy in those with an FEV1 less than or equal to 65% predicted. But by the time you get to 65% predicted, you have a lot of emphysema. We know that emphysema on a CT scan actually precedes an FEV1 less than 80% predicted in almost everybody. So if you had the choice, and now we're entering an age of gene therapies, to actually start a therapy before you get COPD, then many of our patients want that as their way to move forward in this disease. And what that means also is that if you've recognized the disease, and remember with emphysema, there's not a very good correlation with FEV1 because the alveolar component of emphysema is not necessarily an airways disease, except through that alveolar collapse that we ended up seeing on our cartoon. And so what happens here is that emphysema presence and sometimes air trapping and dyspnea, particularly if you're a very active individual or an athlete, precedes any fall in FEV1, and we don't hold therapy back for that group of individuals. Our data is not as strong that augmentation makes a difference in that group, except through a difference in CT density slope that I showed on the previous rapid study. But that's so the point is that I personally don't withhold therapy above 65% if people are symptomatic. We also don't want to give an expensive therapy to people that have no symptoms and some mild emphysema seen on CT. Augmentation therapy, because it's expensive and because we've not done the trials, is not recommended for individuals with the MZ genotype, individuals without lung disease. We don't give it to people that are still smoking because smoking oxidizes the drug that you're giving very, very quickly. And so functionally, you're wasting money if people are still smoking. And we don't give it for liver disease because it doesn't address the mechanism of liver disease, which is the retained protein down in the liver. And so that whole process of who not to give it to is real important. And we recognize there are people getting therapy that really, for which no good treatment has been demonstrated to be a benefit, and particularly in our carrier populations. So if you only test people that have 20% to 30% lung function, and you find somebody that's a carrier, which is 2 to 3% of the U.S. population, then we don't put those people on therapy. We do know in the ZZ population that on the other side, when we get below 30% to 25% to 20%, we're approaching 15% FEV1s, that there's still that mortality signal that has persisted in the NHLBI registry. And there are not enough people at FEV1s less than 10% predicted to prove the difference. But the point is that the theory about how alpha-1 would help protect from infections and from progression of emphysema is sound in this group of individuals. And we actually do have mortality data that suggests that augmentation therapy is still beneficial there. One of the underdiagnosed areas, and now that we have some drugs for bronchiectasis, I think we're going to see more data on how to understand all the different genetics associated with bronchiectasis. But it has been known in the ZZ population that if you do CT scans, then about 95% of them will have at least one airway that is enlarged and dilated. That is, if you kind of ask them, the patients, how many of you have excess sputum, cough, and wheeze, the cardinal features of bronchiectasis, then that number drops down to 27% in David Parr's really good study. And so these airway disease scores, they correlate with your health status. We are going to develop some new CT metrics of airway tapering on CT analysis that help us identify bronchiectasis. But don't forget about testing for alpha-1 in the bronchiectasis patients while you're testing your CF genotypes and other causes of bronchiectasis. We treat the bronchiectasis the same as we do in other areas of COPD, and don't have enough patients to determine if there's an augmentation therapy signal or not. We also know, because alpha-1 is more predominant in a Caucasian population like cystic fibrosis, that there are some individuals that have CF genes and alpha-1 genes, and that makes them even more complicated. So particularly in the bronchiectasis sphere, don't be afraid to test for both diseases. And if you end up with someone who has features of both, then that's more complicated, and we'll not address that in this topic, but they need to go to a specialty center for airways disease. Usually a CF center will help sort out this conundrum. I wanted to end kind of talking about alpha 1 as a disease state. This is through AlphaNet and through the Alpha 1 Foundation, the sister organization. We spend a lot of time educating this community. They tend to be very educated. There are national education days around the country, and to be able to kind of talk to the patients and get them involved with others who have their disease is an important aspect. The COPD Foundation is doing the same thing for COPD. It's just there are a lot more COPD patients than there are alpha 1 patients. And so when you identify an alpha 1 patient, we would love to get them involved. It's about family, and this is a genetic disease, and hope and dyspnea, and all the things that's in this word splash came from one of our patient community meetings that was monitored with their permission and actually used the most common words. And you can see there's a lot of words on here that kind of speak to family and the things that matter to our population. So get them involved is my message. Last thing we're going to end on in the last few minutes here is talking about the drug pipeline. And it's robust. We have some studies going on inhaling alpha 1. We have a new recombinant alpha 1 that is in advanced pipeline that might extend this infusion to longer than a week. We have gene therapy. We have gene correctors. We have RNA correctors. We have small molecule correctors that are attempting to help the alpha 1 molecule fold and therefore get out of the hepatocyte and into the bloodstream, where it may or may not be effective, or may just be effective for liver disease to correct and get the drug out, even if it's not functional. And then we've been experimenting with oral elastase inhibitors, pills in now 4th and 5th generation, to try and inhibit neutral elastase and end up potentially being therapies for COPD as well. And so with all that, if you recognize that the major deficiency happens at the gene level, it makes sense to work as far proximal as you can in this disease. And what that means is that gene therapy, great at the DNA level, at the RNA level, or at the protein level, but also to kind of recognize that if you do this, you're going to be correcting the liver disease. And sometimes our liver endpoints are actually a little bit more robust in our clinical trials pipeline than our lung disease endpoints that include lung function like FEV1, that, as everybody knows, is all over the board, even under best conditions of a good respiratory therapist who's directing care. And so we need to learn a little bit about the liver disease if you have any alpha 1 patients. I thought I'd spend about 5 slides going through the liver disease of alpha 1, because if you become an alpha 1 expert enough to know about the lung disease that we've been talking about, then we at least have to screen for the liver disease along the way as well. Right now, historically, it's been portal hypertension when the liver gets scarred and the pressures go up in the portal vein, that liver disease has been detected. And what this means is all of a sudden somebody shows up and they're having blood coming from esophageal varices, or developing ascites, or splenomegaly and low platelets that happen as a consequence of portal hypertension, which is a very, very, very late stage of liver disease, if you think about it. So you've scarred enough the liver that you can't get blood from that portal vein to move through the liver, and without causing the blood pressures in the portal vein to get higher. And so all those consequences of ascites and encephalopathy and varices are very, very late stages. We want to detect liver disease at a stage that we can treat it. And so historically, we used AST, ALT, GGTs, INRs, and bilirubins. But people with cirrhosis have these as normal tests 85% of the time. And so to move more forward, we're moving up into vibration-controlled transient elastography tests like FibroScans, and trying to figure out stiffness measures of the liver, including MRI elastography, to try and figure out who has liver disease and who doesn't. And this disease that begins as a liver disease. And so clinical liver disease in adults really is all about how much scar is there. And our autopsy studies from the 1990s showed that everybody with disease has scar in the liver, just a question of when and how much it manifests. And then not to scare the patients, but it's going to be 10% of them that end up dying of liver disease, and 2% of patients will get a hepatocellular carcinoma in that group that had cirrhosis. And so there's a lot of liver disease that's here. And if you have a good liver-focused gastroenterologist in your community that can walk step in hand with you to kind of measure and try and do an occasional fiber scan in this group of individuals, it's helpful. But otherwise, in primary care, this is something that we can do. Inside of AlphaNet, we have a thing called the Big Fat Reference Guide. It's online. Anybody can access it. But this chart is in there. It's about our current screening recommendations for alpha-1. And we do note that people that have one Z gene, particularly in combination with the metabolic syndrome, also can have liver disease. And so we think that everybody that has at least a carrier stage should probably get the apple pie and good recommendations for liver-focused care, which is to avoid obesity, don't smoke, because smoking adds to the cirrhosis of liver disease, and to keep alcohol use in moderation, and consider family genetic testing if you have one Z gene. If you start adding, and now you've got two Z genes, and particularly if your ZZ genotype is associated with metabolic syndrome or hepatitis C or some other second hit, then we have to screen much more aggressively, because a lot of the liver disease is thought to be second hit from other injuries and stressors in the liver. So our recommendations for the ZZ population is to get a baseline FibroScan. FibroScan is a proprietary name of a proprietary company, and there are other vibration-controlled transient elastography tools coming other than FibroScan, but it's a stiffness measurement of the liver that is repeated if you don't have extra stiffness every 3 to 5 years. If you have excess kPAs of stiffness in the liver greater than 8, then we think that you should get yearly indexes watching for progression and or enter some of the clinical trials that are liver focused in the world today. We can't make you be liver experts in the 5 minutes that you're hearing about this, but I think it means that in the good care of alpha-1, you need to find somebody in your community that knows this process of how to screen well for liver disease. And we actually have some guidelines coming out soon specifically about alpha-1 liver disease screening guidelines and how to follow up for progression of disease. Once we have a stiff liver, then we think those individuals should be seen by hepatologists. Stiff liver often invites a liver biopsy to understand who has cirrhosis, even if it's compensated, and who doesn't. Cirrhosis has guidelines that say everybody should get an endoscopy to screen for varices. We have the trials of beta blockers to decrease portal pressures that make a difference. We have prevention of ascites with diuretics, and then if you have ascites, prophylaxis to prevent spontaneous bacterial peritonitis. And all those things are focused care for liver disease, but to kind of understand who might have liver disease in an alpha-1 population as a comorbid factor in their lung disease is the goal of at least mention it to get everybody on the same page to recognize that this is a disease and whose pathogenesis requires that the liver is involved when we have lung disease due to alpha-1. So our therapies for liver disease, we've kind of talked about lactulose encephalopathy. Transplantation is a cure. If you get a liver transplant, then those normal liver cells start making alpha-1 again, and so we will stop our augmentation therapies. And yeah, we've got a lot of therapies in the pipeline for liver disease, some of the gene therapies, and also we have a fairly advanced drug for zissaran that is in phase 3 trials right now, which actually is the silencer of the RNA at the transcriptional level and makes alpha-1 levels go to 0. And what that means is the globules then regress, the polymers regress inside the liver, and presumably the liver has regenerative capabilities and can then heal. So we think we have a medicine that might change the natural history of the liver disease of alpha-1. And so if you make the early diagnosis here, those individuals become candidates for our clinical trials. This whole process with fazirsiran is in the middle of studies, and basically it's the subcutaneous injection given every 3 months that moves to and blocks the RISC pathway that makes transcriptional protein production just of the alpha-1. So we can prevent production of alpha-1 without affecting any of the other 5,000 proteins that are in the body. And as a result, fix the defect that's causing disease in these individuals. I'm going to end by inviting everybody to come and look over our disease-specific management program at AlphaNet, one of the organizations that really tries to make a difference with education to our patient community in Alpha-1, similar to the COPD Foundation. And so I'm going to conclude and thank the COPD Foundation for allowing me to chat about Alpha-1. I think a lot of individuals listening to this probably can do a better job at our screening of all patients with COPD for a once-in-a-lifetime test. Diagnosis is only by laboratory testing. You can't look at someone and figure out if they have alpha-1 deficiency or not. Once in a lifetime in every COPD patient. Makes up 1% of all the patients with COPD. So don't be discouraged by having negative test results. That's a great news. Your alpha-1 test is normal. And if it's a rule-out diagnosis in your brain, then that's the way to think about this. But recognize if it's 1%, you might have to test 150 people before you find the first individual, because it is a rare disease. And in that rule, you're going to end up finding 10% of your COPD population that's an MZ carrier. It means you'll have to pause, go through what an MZ carrier state is, and talk about family testing for that group of individuals. You have to be able to explain the MZ and MS carrier state to the patient community. And so we don't have therapy implications, but we do know that those individuals that are more at risk for COPD by virtue of having the one copy of the Z gene and the environmental impact that drives COPD progression that we all know about in the field of COPD. We have lots of treatment options. We want to use them, and we use them in symptomatic individuals. And with this, I really appreciate the COPD Foundation putting on this symposium. The care networks for Alpha-1 are scattered around America at a site near you. You're very welcome to engage with the Alpha-1 community at any level that you choose to. And we think we have the resources to help you get educated and how to take care for our patients in the very best ways. So thank you for having me on. And now everybody on the call is an Alpha-1 expert. Thanks very much.